You're listening to an Airwave Media Podcast.
Welcome to Unbiased Science,
where we bring scientific method to the madness.
We're your hosts, Dr. Jess Steier
and Dr. Sarah Scheinman.
And today we are joined by a very special guest, Dr. Margot Savoy. I'm going to read her very impressive bio in just one moment. There are so many letters after her name, you'll die. We'll tag it all in the show.
I was just thinking that, and I was just thinking, do I even know what all of these are?
No.
I know MD.
Yeah, a real underachiever. But Dr. Savoy is joining us today to talk about some updates to vaccine recommendations. We'll focus specifically on RSV and pneumococcal vaccines, but I think it'll be a really great conversation, and you'll see very quickly why we're so excited to have Dr. Savoy on the pod. So, without further ado, let me read this very impressive bio. So, Dr. Margot Savoy is Senior Vice President of Education, Inclusiveness, and Physician Wellbeing for the American Academy of Family Physicians, Associate Professor of Family and Community Medicine and Urban Bioethics and Population Health at the Lewis Katz School of Medicine, and Associate Professor at the Maurice Kornberg School of Dentistry at Temple University. She completed a postdoctoral fellowship in vaccine science with the American Academy of Family Physicians. In addition to being a speaker and author on immunizations and related topics, she has served on CDC's Advisory Committee on Immunization Practices, ACIP, as the AAFP liaison, as well as on several ACIP working groups. Dr. Savoy, thank you so much for joining us.
Thank you so much for inviting me. I'm so excited. I watch you guys, so this is actually a really cool moment for me. So thank you.
Oh my gosh, Diane.
Wow.
I know. Isn't it
fan, Jess?
All right. So when it comes to vaccines, one size doesn't always fit all, right? So today we're really going to do a deep dive into risk-based vaccine recommendations, what they are, why they matter, and how they're transforming protection against RSV and pneumococcal diseases. So, Dr. Savoy, many people assume that all vaccines follow the same universal recommendations, but risk-based recommendations are becoming more common. So can you maybe let's take a step back and start explaining why this shift is happening and how it improves public health?
And maybe also if you could just define for us, what is a risk-based vaccine recommendation as well, please?
So this is such a great question to start with, because I think it's one where I know in the office we hear this question a lot. Why do I need this one but not that one? Why did my family member get one but I didn't get one? And so it starts this sort of interesting dialogue. So one of the things to think about is that when they do vaccine research, it takes a really long time, so that you're trying to prevent a disease. So you have to wait a super long time to know whether the person never really got the disease or whether they never had a problem with the disease. And so it takes an incredibly long amount of runway to know whether people can have a vaccine. And sometimes that runway is so long that you would end up losing an entire generation having access to a vaccine if you had to wait until the study was all the way finished before you would know whether it's good, bad, or indifferent. And so what they do is, instead of waiting until the very end, so 30 years later, decide, hey, yes, let's do that or not, they study the populations in the group that's getting the sort of study happening. And 30 years later, you're going to know, that was good, bad, or indifferent. But in reality, you can find out a lot of signals early on. And what they do is look for who are the groups of people who are getting just sort of more money than they ever could have thought they were investing out of this vaccine. So that you gave everybody the vaccine the way you thought you would in the trial. And this one group is just popping off. They're doing so great that, you know what, we don't want to wait 30 more years to give them the vaccine. We want to go ahead and give it to them. Or you looked at them and you were like, we know we made this vaccine, but we made it for everybody. Yet there's this one group that particularly has a bad time when they get that particular infection. And you watch that group really closely. So you get a huge number of people in that group and figure out whether or not that particular age group really needs this vaccine. Or, for example, people with this particular disorder or disease really need this vaccine because, you know what, that person has a higher risk of dying or having some kind of bad thing happen to them if they happen to get the infection. And so those are the two ways that they sometimes can set up their study ahead of time so they don't have to wait the whole 30 or 40 years to figure out that, yes, you really did have a lower chance of getting this infection or that infection. And so what it means is that sometimes you'll get a brand new version of a vaccine that comes out and people are like, this is a great vaccine. It does all the best things ever, but it's only for people who are 2 years and younger, or it's only for people who are 55 and older. And you're like, well, I'm 54. Why can't I have one? And it's not necessarily that you can't have one. I mean, it's not that something bad is going to happen to you if you got it outside of the age range. What it is that they didn't really study it well enough in that group to say, we know that you're really going to get a benefit. And so we absolutely want to make sure you get it. And if they're not sure, they don't just want to give everybody vaccine for any old reason. If for no other reason, you might run out of vaccines for the people who truly needed it, or it's a waste of money. It's you getting a stick that you didn't need to have. I mean, there's just a lot of reasons why you don't just give people things just for kicks and giggles. And so they say, wow, I don't know that I want to give everybody this vaccine. Let's target it to the people who really need it. And as we're doing those ongoing studies, if we find that there's other groups who would benefit, you can add them later too. And then if we get to the place where everybody seems like they benefit, then you give that universal recommendation, kind of like with flu shots, where they're like, everybody 6 months and older should just get a flu shot. So you can get to that place. And in some groups, you find that really early on. And in others, the vaccine was made for a really specific targeted group of people. And not everybody was at the same risk for getting that disease. So not everybody necessarily needs the vaccine.
And Dr. Savoy, you said something that I think is worth really underscoring. If there is ever a safety signal, we're not talking about safety, right? These vaccines, if they're hitting the market, if they're being deployed, we know based on a ton of studies, right? Preclinical, clinical, all the trials that have to happen before a vaccine hits the market, that they're safe. It's just about which groups would benefit from them most, right? So we're talking more efficacy versus safety.
Absolutely. So, I mean, I think it's interesting. Like one of the things that I think about a lot is that people often are nervous because you're injecting the thing in your body. It feels like you can't undo it once you put the needle in. It's just sort of all over. And so people are like, well, are you sure? Are you double sure? And the interesting part is the people who review your drugs and medications want to be triple sure before they put it in your arm because they can't take it back out either. And so they want to make sure that the thing that they're giving you makes sense. And so all of these vaccines have gone through years on years of development before they ever even get to the stage where you're going to be getting that vaccine. The other part that I personally find very reassuring, and I think about this a lot, just because, I too am a patient, right? So, I mean, I got to give recommendations to my family and I got to decide what I want to do for myself. What I find the most reassuring is that even after the vaccine is in the market, people continue to study it so that, in my office, if you come in and I gave you a vaccine and you had a reaction, even if it was something kind of minor, so you had swelling or something that just didn't seem like the kind of thing that was showing up in the package insert, I have an easy place to report it so that they can track that and they pay attention to those signals. And so if people are having a problem, those signals come back up and we can decide if we need to make a change or alert people or figure out that there's a particular group that's having, more of a challenge than another. But it is surprisingly uncommon how many of those things are truly things that you'd be very nervous about. So most of the time they come back and they're like, people may have pain at the injection site. And you're like, kind of could have predicted that one. I mean, so yeah, okay.
Right.
Thank you. I mean, I appreciate that, right? But I don't know that would have stopped me from not wanting to die from whatever the disease was I was trying to prevent. So that's good notice. Thank you. But I don't want to do something different. And every now and again, there's a rare thing that shows up that you might not have seen until you got to the tens of millions of people who've gotten the vaccine. And again, I don't know that that's enough for me to not necessarily feel like they're safe or feel like they're not effective. I think the fact that they're so tracked and so paid attention to is reassuring, not the other way around.
Right. So what I'm hearing from you is that these recommendations can be very dynamic, like as we're getting more information in the scientific and medical communities, that really it's not necessarily a rigid set in stone kind of thing.
I would completely agree with that statement. So when I think about the ACIP you mentioned earlier, so there's a committee, which isn't always the same people. So even the committee isn't static. So it's organized of the same groups of people, so the same types of people sitting around the table, but who the individuals are changes. So they've got terms. And the idea is to get scientists together and physicians and clinicians together, people who make public health decisions together, people who do policy decisions together, and really have a conversation about what it is in the schedule. So literally every year, they have a new conversation about every single vaccine that's on the schedule. And do these still belong here? Are they still appropriate? Are there new vaccines that are coming? Are there new ones that would be better than the ones that are here? Or are they just added to the list that we have? And so I mean, having sat through those meetings, for some people, they're probably kind of boring. I thought they were awesome. I mean, I found them really intriguing. I enjoyed the science and hearing how people think about it. They go deep. I mean, they talk about not just what's happening with the people and exactly how many people had exactly what reaction. But they also talk about things like, is this cost effective? And would we be adding a lot of expense to people's lives, but not really getting them any benefit? Could we be hurting or harming them? And people get a chance to come and speak and tell their story. They also get a chance to hear the data and really dig into what the scientists were looking at and why they think that makes sense. And then that committee gets together and makes a recommendation. So it's not, one rogue person with a pen being like, everybody gets this thing. Mm-hmm. It's not the manufacturer on its own getting a pen. I mean, they don't even get a seat at the table that votes. They get to stand up and talk. They don't even get a seat at the table. I mean, they don't really get to vote. And so to me, that's really reassuring. I mean, it just makes you feel better. Like you can watch it. Like if you really are, if you really want to nerding out about it, like you can actually watch it on the computer. Like it's video recorded. It's one of those federal advisory committees. So you can read the transcript if you want. So there's nothing that's happening that's sort of behind closed doors or, shady about it. And I love it because there are times when they don't actually agree, like where you can actually watch the people go, I don't know how I feel about that. My organization feels like this. And the other one's like, well, I feel like that. And they're looking at the same data. And that happens with scientists all the time. We're looking at the same data. It's not quite clear. You could go either way. And the answer is usually we need to get more data. In the meantime, let's do what's right for the people. Well, then they have that conversation. They vote it out. And so to me, that's reassuring. But that also means that today, I might tell you to go to the left, and by 2 years from now, I might need to tell you to go to the right. But your doctor should be able to explain to you why they made the shift. So it's not that they're randomly deciding go left, go right, go left, go right. It's more, hey, you know what? They got more data in the last 2 years. And so now they're saying, really, maybe the left wasn't the best way to go. Let's go to the right. And so I feel like that fact that people are having those discussions, again, this is the kind of stuff that I think sometimes people interpret as, wavering or waffling or being uncertain. And for me, I need you to want your scientists to be uncertain. I need them to be challenging what they think they know every single time. Every single time. Like, so just because your conclusion worked the first time does not mean it's going to work the other 50 times. And the beauty of science is I want you to do the other 49 trials anyway, just in case, so that in the end, I feel even more confident, because the world is ever changing and your science is ever changing. And so, honestly, if somebody got up in front of me and was like, I made this recommendation and I'm going to leave it for the next 500 years, I would not trust that scientist, because I'd be like, you have no curiosity left? Like, no, that's not the doctor you want. That's not the scientist you want. So you want them to be
I'm working on a preclinical study right now on a specific combination of pharmaceuticals to treat Alzheimer's disease. But I'm working in mice. And a lot of people think that, scientists just sit around going like, eureka, we got it. But like also much of the time I'm like, like that's interesting. I really didn't think it was going to work like this. But, it ended up work. I thought we were going to go right. We're going left. And that's kind of my favorite thing about the scientific process.
And Dr. Savoy, what I love about how, first of all, I'm obsessed with you. I want to be best friends with you. I love the way that you're explaining all these things, and you're giving a level of detail and nuance that is so much more impactful than just vaccines are safe and effective, right? Like it's that, first of all, we've heard that a million times, but like you're explaining the process. And again, just for I'm going to beat a dead horse here. We're not talking about safety, right? The vaccine, that's not what we're debating here. We're talking about really like targeted recommendations, who would benefit most. So getting into some of the different types of recommendations. So I sort of see four main buckets. Tell me if I'm wrong, but there are routine recommendations, which are, universal protection for general population or perhaps specific age groups. Then there are catch-up recommendations, so getting people up to date who missed earlier doses. There are risk-based recommendations. So these are targeted protection for specific high-risk groups, and shared clinical decision-making, individual decisions based on personal factors. So I think those last two are something that we should maybe dig into a bit more. So can you maybe give us an example of how shared clinical decision-making, first of all, what it is and how it differs from risk-based recommendations in a real-world scenario?
Absolutely. So if it makes you feel better, some of the doctors need this update too. So risk-based recommendations are the older of the two. So it's not been uncommon for us to have risk-based recommendations. That's been around a really long time. And the idea is that, earlier when we were talking about sometimes you just know somebody gets more sick from a certain thing. So you get a whole bunch of those people together and you do a trial where you're trying to study it in them. And you say, yeah, you know what? It turns out kids are more likely to die from this particular infection. So let's study a lot of kids and make sure that we know that for kids, this is most important. And so then the risk may be their age. And so you say, okay, for this particular vaccine, your age may be the risk factor. But for most of those groups, that becomes a routine recommendation because it's the whole swath of kids at that particular age. But there may be a group of kids, for example, kids who don't have a spleen. So for one reason or another, they don't have a spleen anymore. They had an accident, it had to be removed. They have sickle cell disease, so it auto-infarcted, or it sort of, over time, it damaged itself so much it doesn't work right anymore. So their spleen just doesn't work. Well, those kids may need specific vaccines that look different than every other kid their age. So they still may need all those routine ones. They still may need to get caught up if they missed one. But in that particular group, I may need to give you an extra dose of something because your body isn't able to react the same way I would have needed it to get the same level of protection as the other person. And so it's not usually that you're trying to exclude people. It's actually that you're trying to intentionally include the people for whom that particular vaccine would be more helpful. Mm-hmm. And so risk-based recommendations come up a lot. Sometimes they're age-related. Sometimes they're disease-specific related. Sometimes they're related to where you're going. So if you think about it, like there's risk-based recommendations if you're going to a particular part of the world where that infection happens to be a lot higher. If where you're from, it's not there, but you got to go to this part of the world and they do have it there. You may have to go get that vaccine only because you changed your risk by going to the place where that thing happens more often, or by taking a job as a lab worker where now suddenly you're working with that particular bacteria or virus. And now suddenly you changed your risk. And now that you're in that risk group, you need to have that recommendation. That's different than shared decision-making. So shared decision-making is the newest of the four. And it shouldn't be a stretch to people, but I mean, it's sort of this idea that I told you that not everybody's going to have already been in the study that tells you that you deserve to get the thing just because of who you are or just because of your risk or whatever. Actually, deserve is probably the wrong word. It's sort of that you sort of need to have it because you get to the place where that's the infection you have, or you finally reach that coveted age of 55 or whatever the thing is that people have decided is that routine recommendation reason. Well, what if you are 54 and you are really, really concerned and you want to get that vaccine anyway? There are a lot of vaccines, like we say about the safety part. It's not that it's unsafe that you get it. It just isn't really recommended. Like they don't know that you need to have that. But what if you wanted to have it anyway? The idea is that shared clinical decision-making gives you the opportunity as the patient to have the conversation with your doctor about whether or not it actually makes sense for you to get it for you. And so there may be most people for whom they're like, you know what, I know you're 54 and 54 is a hair's breadth away from 55, but honestly, that year is not going to make that big a difference for you. I don't think you need this. You can let it go. And you might want to have a discussion about, well, I'm more concerned because of this and this and this, and it makes me nervous and I want to do whatever. And then you guys have the conversation and they give you the science and you make the decision based on what you want to do. And so there's some vaccines that have been released, particularly more recently, where they put out the vaccine. They know that other people might want to have it, even though they really couldn't show you data that says that all of those folks need to get it as a routine. Everybody just gets it at that age. But they're like, honestly, if people really wanted to do it, y'all should have a conversation and talk about it. The most famous one for me, the one that shows up in my office most often is HPV vaccine. So HPV vaccine very clearly was recommended for adolescents. So it came out and they were like 9 to 12 was sort of the age range. Most of the time people get around 11 to 12. But then over time, people my age were like, time out. This vaccine wasn't around when I was 11 to 12. Why don't I get to be protected from cervical cancer? What's up with that? And when they did the studies, they realized, there's some benefit for some people if they actually got that vaccine. So everybody routinely probably shouldn't get that vaccine at your age, Margot, but you should go have a conversation with your doctor. Because if you and your doctor figure out that you're in that group that should do it, then you should go ahead and get it. And if you guys talk about it and you don't think you need it, then you probably shouldn't get it. Mm-hmm. And so it opens up an opportunity for a conversation. To be fair, I think all vaccine conversations are opportunities for conversations, right? So even the routine ones, if you've got questions, you should certainly ask your questions and make sure that you understand why people are recommending things for you. But the ones that are routine are the ones where they've got data that show that whole population needs it. Whereas for the shared clinical decision-making, I'm telling you up front, I don't know that it's going to necessarily help you specifically. But if you want to talk through it, let's talk through it, because there may be individuals for whom that's a really great idea. And we don't want to miss them, like just because they didn't fit that whole big population approach.
So I feel like there are going to be people listening who are like, aren't we splitting hairs between, shared clinical decision making and risk-based? And I think it's really interesting that you brought up HPV. And I know we're going to talk specifically about RSV, which actually recently shifted, as well as the pneumococcal vaccine recommendations. But for HPV, we have a lot of people who are like, oh, I want to get the vaccine, but it's not covered. So there are other considerations, right? Because these recommendations and, policies and the way that we structure the recommendations, that will influence coverage, right? Whether these vaccines are paid for by insurance providers. So I don't know if you had any commentary on that, like the impact, the real impact, some other considerations for patients and providers.
Yeah. So one of the reasons why it's important that they put that as its own sort of bucket of things is that one of the steps in that ACIP process is to decide whether or not they're going to cover it for Medicare or Medicaid. And if their answer is no, most insurance companies are going to follow Medicare and Medicaid, and so then they won't really cover it either. And so sometimes it's problematic. I mean, there's probably an instance somewhere in time where, everybody else covered it and Medicare and Medicaid didn't, but offhand, I can't think of one. And so it usually goes the other way around. And so when you can put something into one of the recommendation buckets, it gives you the opportunity for the other insurers to choose to pick it up. It doesn't mean that every plan will. So, some plans will say, Margot, I get it. You want to go get that vaccine that I don't think you need? Well, then you got to pay for it. I don't want to pay for it. You figure that out. But what it also means is that you can also get it paid for sometimes by your other sort of those adjunct plans where you have like your health savings account or some of the other things. And so it's a lot of, legal stuff in the background that sort of makes all of the payment coverage things work out. But it just gives you a bucket to put it in so that it even makes it possible for it to get covered. Otherwise, it may never go into that determination part where people decide whether they want to pay for it or not. And it would take, a patient wanting to go and appeal it and go through that whole process sometimes even to kick it off for anybody. And so this way, before it even gets started, often you can get some indication of whether or not it may be covered or partly covered, or particularly for children, whether it ends up being in the CHIP process so that they can actually get it for free through the government-sponsored vaccines. And so it does matter. It matters. And the answer to your question is, are you splitting hairs? And my answer is yes. All of this stuff is splitting hairs. Right. Even catch-up recommendations, right? So catch-up is just how fast can I catch a person up off the routine schedule that they had? And folks are like, yeah, but you would just give it to them. And I'm like, yeah, but, there's like some nuances about it. Is it 4 weeks or 30 days? And, there's some things that show up. All of this is splitting hairs. And for me, you want me to split hairs because, again, you don't want me just randomly telling you to do stuff or just, changing my mind one way or the other. And so this lets you cut out the nuance.
Someone's got to split the hairs.
Yes.
You can't have unsplit hairs.
Oh, gosh.
Not in science.
All right. So speaking of splitting hairs, let's talk about RSV.
Sorry.
So my understanding is that we recently shifted, I guess in 2024, right, from shared clinical decision-making to risk-based recommendations for RSV. So let's talk about it. Can you maybe just talk a little bit about, first of all, what is RSV, who's at risk, and how these recommendations changed and why?
Yeah, RSV is a fun one because I feel like people were like, a new thing showed up during COVID and we're all going to die. And I'm like, well, what's the new thing? And they're like, RSV. I'm like, that's not new. So, for people who take care of children, RSV has been around for a long time. It's quite common. It's one of the sort of early childhood diseases. People get it and everybody sort of chalks all of it up to being a cold. So in the wintertime, back in the day when I was young, everybody either had stomach flu, regular flu, or a cold. Those are the three buckets. And so it didn't matter what actual virus or thing you had. Every now and again, people would throw in pneumonia and the walking pneumonia or the not walking pneumonia. But for the most part, people were like, you got a cold. Well, it turns out a cold isn't actually a thing. There's a lot of different viruses that can create upper respiratory infections that can cause trouble. And RSV became really important because there really was an outbreak of RSV. It became almost like that third part of the pandemic, which is what people were saying there was a triple demic when we had flu season, COVID, and then we added RSV on top of it. Historically, you get nervous about it in children, but most of the kids don't necessarily die from it. But there were groups of kids who were a little bit more affected. And so we had really targeted recommendations around specific pockets of kids who maybe needed certain medications. And we had treatments, but not always the best treatments. And we had vaccines, but they weren't necessarily ones that were being given to a lot of people because there just wasn't a reason to do it. what they have seen as they've been studying it, and they actually had started studying it well before COVID and well before the pandemic. So this is another one of those times where it looks like it all of a sudden happened because it hit the news cycle, but it actually had been going on even before. That what they had noticed is that people who are older don't get diagnosed with RSV as often, but when they do get RSV, they get very sick and they often pass away. And sometimes it's the reason why the person in the ICU who's older dies. And before COVID, so if you didn't have COVID, in this sort of mix where a whole lot of people ended up in the ICU and are having respiratory failure from that, RSV was up there with pneumonia as reasons why people were dying or having secondary infections and having problems in this older age group. And so they had been looking at, well, why would why would these older adults all of a sudden have this problem? And should we be doing something about that? And so if we've got this RSV vaccine, we've been giving it to kids. The idea is if you gave it to enough kids, maybe you could vaccinate it out of the system. And so you don't have to worry about the older adults because it's just not floating around. And it turns out it's not that easy to vaccinate it out of the system. And so kids were still getting sick every now and again. And those kids are bringing it home to grandma or grandpa, and grandma or grandpa was ending up in the hospital. And so could we give it to grandma or grandpa? Would that make sense? And in the early studies, it looked like the answer was probably not. We don't really have enough data to say that was really going to make a difference. We don't really know that their immune system is going to respond the same way. And again, not a safety issue where you were going to hurt them by giving them the vaccine, but the older we are, the less robust our immune system is when we give you a vaccine. So sometimes you actually need a different dose of that vaccine as an older age group. So are we giving them would it be the right amount if I gave you the same dose for kids? When do you need it? How often do you need it? There's just a lot of questions that hadn't been answered. And so they were able to find that it turns out there is a group of people for whom this vaccine would help. And it turns out when you give them the vaccine, even if they end up in the hospital, they don't die. And that's a win. And so they really changed their mind about how they wanted to approach it. And so instead of doing the shared decision making where you're having a discussion about whether or not you want to do it or don't want to do it, which is how we started, because you could have a discussion with some of your older patients and be like, you got COPD and it's making me nervous. And you really do end up in the hospital a lot and your lungs don't have a lot of reserve. So you're making me nervous. I think you should do this because if you got RSV, it'd be bad for you. That's the conversations we were having before. Shared decision-making, individual people, I'm just talking to you because you're making me nervous, to a bigger, broader recommendation where you'd be like, your risk factor may just be your age. And so let's just tell those groups of folks. So it doesn't mean that everybody now needs to go do it. So it's not a routine recommendation, but this age group probably really needs to do that. And so there's an interesting thing that with RSV specifically is that data actually looked different, even in the older adult group, depending on exactly what age you were, which I thought was fascinating. And so if you're 75 and older, they were like, nah, homie, you need to be vaccinated. Nah. So I don't want to have a shared decision-making conversation right now. I just don't, I want to be crystal clear that I strongly think you need to have this vaccine if you're 75 and older, because the data showed that giving y'all that vaccine when you're that age really made a huge difference and it was saving lives. But if you're 60 to 74, I really think you should get it. In fact, I still strongly recommend it, but not everybody. You got to really look and see who you are. So certain people really need it a little bit more than others. And so let's go back to this risk-based thing where I tell you, you're in the bucket that really needs to be concerned or not concerned. And I think that's a really great story of, really looking at the data, paying attention to what's going on, and then quite honestly, watching the evolution of the things that are happening. This is your public health service at work. This is literally why we track data. This is why we track epidemics and things that are going on, because that RSV epidemic allowed people to see so fast what it was, how it was happening. And then that vaccine ability to be able to be like, whoa, we had a bunch of people who now suddenly have this thing they don't normally have. And all of a sudden we can make it better. And here we are, we're able to accelerate some of the work. So I never cheer for an epidemic, but if we're going to have a disaster, let's make the best use of that disaster so that people don't have to live through that again. And so that's,
let's learn
is a really great opportunity. And I'm excited because it gives you the opportunity to have the discussions in a really targeted way for the person that you're taking care of. So it's not, hey, it's up to you, kind of think about it. Which feels sometimes to me like dumping the weight of the choice on the patient. This becomes more that hey, gang, I can be real confident about this data and real confident about that data. And they have it for me. That makes me feel better. I mean, you still may decide that you're not going to get it. And we can talk about that too. But like at the end of the day, I can tell you that I got data. So I went from not having enough data to feel confident about it for everybody to having data for these groups of people to tell you I feel good about it. And you guys got to watch that happen in real time, which to me is exciting.
So I'm going to summarize the shift just very briefly before we maybe move on to pneumococcal disease. And Sarah, I was thinking maybe you could give like a 1-minute tutorial on immunosenescence and like why age is such a big deal when we're talking about immune function and why, vaccines can sort of vary or their effectiveness can vary based on age and all that good stuff. But before I turn it over to you, I'm just going to summarize what I heard Dr. Savoy say and sprinkle in just a statistic that I thought was really powerful. So RSV vaccines just recently underwent a significant shift, right? So initially, guidance for adults 60 and older followed a shared clinical decision-making approach, leaving the choice to patients and providers based on individual factors. However, as we collected more data, as we reviewed the data, as Dr. Savoy said, we saw really strong vaccine effectiveness, looking at reduced hospitalization risk in the ballpark of 75 to 82%, which really highlighted a higher disease burden in certain populations. And this led our recommendations to evolve. And then this past year, we moved to a more structured risk-based approach. So universal vaccination for adults 75 and older, while those aged 60 to 74 now qualify based on specific risk factors. So Sarah, before we move on to pneumococcal, can you maybe just chat briefly about the immune system as we age?
Broadly speaking, our immune system undergoes a couple of different changes that can affect its ability to respond to infections, like as we age. And these changes that are associated with the natural aging process are kind of broadly referred to as immunosenescence. And this is a really complicated subject. Like people will devote their entire lives to studying immunosenescence. And there is a lot of controversy in the field as to what is exactly involved in it. But there are a couple of the main points is that there is sort of a very broad decrease in the production of immune cells, a decrease in the production of immune cells. So this can be due to, some people think that this is because the thymus is shrinking and that there's maybe lower bone marrow function. There also is a weakening of the existing immune cells too. So weakenings in both the T cell and B cell, both function and diversity. So the different types of these cells, there's just less diversity, which makes them very much more impaired when it comes to responding to the different infections too. So you've got a decrease in the overall production, a weakening of the existing cells in the immune system. There's also a sort of an increase in overall inflammation levels as you age. There's sort of this pithy term in the scientific community that's called inflammaging, that I just get a kick out of it because I just love a good pun. But it does what it's referring to is sort of a chronic low grade inflammation as we age. And I think anyone who is sort of over the age of 30 can sort of attest to the fact that things aren't as smooth as they were when we were teenagers, right? For example, as I get out of bed in the morning, have a bit of a creaky back now. That did not happen when I was 21, but at 31, I'm oh, this is fun. This is new. So, that's just one example, but there is sort of a chronic low grade level of inflammation that exists as we age. And it just speaks to the altered state of the immune system as we age. And there are many things that can change that can affect our immune system overall. And aging is kind of just one of them. And it can change, most importantly to our discussion today, lead to an impaired vaccine response as well. So I think that all of this is, plays into why the recommendations are often very much based on age. Is that correct, Dr. Savoy?
Yeah, it is. That's actually a really, really, really great explanation of it. I always think about it that at the time when you get to the part where you tell people to get off your lawn, your immune system is tired of fighting you. So it's whatever. And so it's not really entirely accurate, but it just feels sometimes your body can't do what it used to do when it was younger quite as fast. But it means you're at a bigger risk for those infections. But it also means that the same system that we were sort of exploiting a little bit to make you immune, it's I'm a bit tired. What are we doing? So you may have to poke it twice instead of just once, right? To get it to actually have that same reaction. And so it hurts you in two ways. And so we can sometimes combat that. And it's such a great way of explaining it. I just think sometimes we don't think about it. Like you just think, I'm getting older. But, it's really important. This is one of those splitting hairs moments. I mean, it's really important that once you get to a certain part where you might have needed a different dose, we might have thought it didn't work. And it turned out we just weren't using the right dose for you. And it made a huge difference when we picked the right one. And so really great opportunity to dive in and look a little bit deeper and make sure that we're really getting that right group of people covered for the right thing.
All right. So the next thing we're going to talk about is the pneumococcal vaccine. So can you tell us, first of all, what is pneumococcal disease? And maybe we could just chat about the recommendations for pneumococcal vaccines.
Yeah. So pneumococcal vaccines are going after a specific kind of bacteria that causes pneumonia. So, I always found this one funny because it turns out there's more than one kind, but it turns out that, I don't know, back in the day, everything was all walk-in pneumonia, but it turns out there's actual bacteria that are causing you to get pneumonia. And so you can actually give people the vaccine to try to prevent the pneumonia. The interesting thing is that it doesn't only cause pneumonia. So that's the part that I found most surprising. So it turns out that kids sometimes can get infected by these bacteria. And in them, it may look like an ear infection or it may look like upper respiratory stuff. But in older adults, it usually looks like a pneumonia, but sometimes it looks like something really serious and scary that we call sepsis, which is sort of an overwhelming infection sort of everywhere with that bacteria. And so the reason why we started giving the vaccine in the beginning, this is kind of similar to RSV in a little bit, that we started giving it to people who were children because we were like, the kids are getting these really bad ear infections. And sometimes those ear infections are making them super sick. And so let's actually, address them first. And so we really spent a lot of time and energy vaccinating kids. And the idea was, we know sometimes adults get it, but it's really not that common in adults. And so if we get it out of the kids so that the kids aren't having it quite as often, there'll be less of it floating around in society. So less of the adults will get sick and will be good. And that seemed like it worked for a little bit, but then it turns out there were new serotypes of it showing up. There were different ways. And so that vaccine has evolved over time to have different types so that, even for the folks who were taking care of their kids, they realized there was transition from how many types of pneumonia could be prevented depending on which one you got, and then people had to transition over. So this is another great example of a vaccine that keeps evolving because people are really paying attention to what's going on. And so when they saw new forms showing up, they were like, hey, let's tweak this vaccine and get it right for them. But then what they noticed is that we're tweaking the vaccine and we're getting things right for kids. But these adults, 65 and older, are still showing up with pneumonia. And so is it all the adults who are 65? Again, is this just a function of age or is it truly a function of something else? Is it the diabetes? Is it the heart disease? Is it, the liver disease? What is it that's actually causing the problem? And should we think this through a little bit different? And so the answer turned out to be yes. And we were like, wait, what does that mean? And so this one has been changing a lot. And even for physicians, they have to pause for a second and go back and look and make sure that they're really giving you the right recommendation because it's changed a few times over the last few years because they had some really big studies come through that really helped answer the questions. So now you've got sort of age-specific recommendations. So if you're a child under 5, you're going to get pneumococcal vaccine. If you're an adult who's over 65, you're going to get pneumococcal vaccine. So I should say, we're going to strongly recommend it as a universal recommendation that you get it. They're going to try to tell you that, we really think that's true. Because in those groups, vaccinating everybody just makes sense. For what you're preventing, for what you're trying to prevent happening to them. So that getting admitted to the hospital, that dying from pneumonia definitely matters. And for kids, the ear infections really makes a difference. But then there's people in that in-between group. So between, age 6 and age 64, who honestly are at higher risk and shouldn't wait until they're 65 to get that vaccine. And in fact, they need to be paid close attention to, so much so that, your doctor's office probably has triggered all of these disorders as things or these factors for them as things to remind them because it's such a long list that you may actually need to do something different. And so these are people with chronic heart disease, chronic lung disease, diabetes, chronic liver disease. So medical conditions that just put you at higher risk. They're not randomly pulling them out of their hat. These are folks who you were like, folks who have diabetes seem like they end up in the hospital a lot more. And when they ended up in the hospital, what they were dying from was this pneumococcal pneumonia. And so they're like, we need to look at that closer. And the answer is, they actually were. So we give them the vaccine to prevent it. Then there's immune status things. So kind of like we talked about earlier with the immunosenescence, there are other things that you can do that can impact your immune system. Sometimes medications that you take or certain things that you do can cause that trouble. But in this case, those aren't the folks they were necessarily as worried about. It was people who had like congenital immune deficiencies. So if I was born and my immune system just doesn't work as well as it's supposed to, I can't protect myself against the particular bacteria that's causing the pneumococcal infection. Or if I have HIV infection, I just can't protect myself as well as I want to. And then turns out people who have chronic renal failure, so not necessarily just people on dialysis, but people who have renal failure that is chronic, can sometimes really struggle to protect themselves against this particular bacteria. And so then those folks, even if they're not yet 65, and even if they're not under the age of 5, really need to be strongly considered to have this vaccine. And then there's some lifestyle factors. So that for me is the interesting one that people don't often remember. And so some, the earlier ones for most doctors are kind of obvious to them, like the way that this bacteria works, it's got a capsule. And so anybody that can't fight that capsule, you get nervous about. And so like in your head, there's a set of triggers that sort of makes you think to reach out to those particular patients. But the lifestyle factors one I think is interesting because many people don't think about the fact that really chronic alcohol use and alcoholism puts you at a higher risk. And you don't necessarily have to get all the way to the chronic liver disease part of alcoholism to actually have an impact. And so significant alcohol use might be a reason. The fact that you're a smoker becomes a reason. I don't have to wait until you get COPD to know that you need to be protected. And so that becomes a risk. And then there's some environmental exposures that we know about that can also cause some trouble. So knowing where people work and what they're exposed to in their day-to-day life makes a big difference. And so that is an incredible list. So doctors usually do lists of 3. Like this list is a list of like 9 or 10 things. And even under some of those things, there's a list of things. And so what you'll find is that it feels like all of a sudden we're recommending stuff to everybody. But it's not to everybody. There's a whole lot of adults for whom none of these things count, and they can wait till they're 65 and be totally good, and there's not an issue. But if you're one of those adults that falls in that group, we should be having a conversation because you really are at risk. And this isn't just the shared decision-making one where we're waiting for you to decide that you might want to do it and have a discussion. We, your medical community, should be telling you, I am nervous for you. You're at higher risk. Let me tell you why, and having that conversation that way.
Wow. You are the queen of explaining things. I have to make one plea. So my background, Dr. Savoy, I haven't shared with you, but I came from the world of tobacco control, lost my father to COPD-related complications. So anything smoking-related, like that's my jam. So I think it's really interesting that you bring that up. And whenever I have the chance to get in the ear of a clinician, I always say, rather than asking a person if they're a smoker, because some folks don't identify as a smoker or they don't think of their smoking history as significant, even though it is, I always say instead try to frame it as, how many cigarettes do you smoke a week or how many cigarettes do you smoke a month? Because then you're picking up on those, non-daily smokers. That was just
that makes sense.
My soapbox. All right. So we covered a lot of ground here. I do have just one sort of final question. If you have any final thoughts to share with folks, I guess, we're talking about how these recommendations are evolving. So if you had a crystal ball, like what do you see coming next? Any final thoughts or anything that we didn't cover that you want to share with folks?
So the biggest thing that I think I would want to share with people is that I don't think that immunizations are going to go away. The technology is actually really important and it has the ability to do things even beyond what we use it for today. And so we spent all of our time today talking about immunizing against infectious diseases, so things that you could catch, specifically viruses and bacteria. But there are ways that you can use that same technology that you can sort of exploit that immune system's desire to want to protect you to do other things. And so there are vaccines that are being looked at for a wide variety of things. And so the idea that at some point vaccines are all just going to go away and this is all going to get simpler is probably not true. I actually think it's going to continue. I think it's going to get more complicated. I think it's beautiful that it's going to get more complicated because it means that there's going to be more studies and more options for people and things that just do a better job. And so even in the times where it feels like, I don't know why I have to do this certain thing every year, or how come the shot I got last year is different than the shot I got this year. I just encourage people to ask the question because I think it's a good conversation. I think there's never a bad reason to ask your family doc a question. If you want to know the answer, you got to ask the question. But I also think that be open-minded to the idea that maybe it's not because there was something wrong with the last one. They just made it better. And so, in many other parts of society, we want the upgrade. I don't know. I keep getting talked into buying new iPhones. There was nothing wrong with my old iPhone. My old iPhone was fine. But you still suckered me into getting the new one. But the reality is that the new one actually is better. So it's not even that I got tricked. It truly is better. You figured out how to do things that just make it more efficient, faster, do the things it's supposed to do. And so, I was really in love with that wee little iPhone way back, 10 years ago. And yeah, the one that I have today actually does do better. And so vaccines, I want them to be like iPhones. I want people to be coming up with new models and thinking of new ways to use it and thinking about features I didn't know I needed, but you just protected me against something I wasn't even thinking about. And I just encourage people to find a safe place to get their information so that, on social media, there are a lot of people who can have a lot of weird credentials and do a lot of weird things. And so it's not that I think social media is bad. I actually enjoy a good Reddit scroll. But the reality is that, like, at the end of the day, you got to know who you're listening to and where they're coming from and whether or not what they're saying is based in science and truth and it's really accurate. And I think that, professional societies, obviously I think AAFP is a great one because it's one that I work for. But even before I worked here, I'm a family doctor. And honestly, I've spent a lot of time doing a lot of this committee work. And we rib them hard about making sure that they get the evidence right. You can't just jump forward and do stuff because it sounds like it's fun or it seems like a nice thing or it would make people happy. You got to stand on the evidence. And that is really important. And so for me, it happens to be AFP. For you, it may be something different. But what I think about is at the end of the day, you got to find the one that's safe for you, that's going to give you the unbiased approach, that ability to see the information, to see both sides of the information so you can make the right decision. And I don't know that that's everything you read on social media. I think you're going to have to do a little bit more digging, and headlines aren't always the answer. And so I just really encourage people to have the conversation. And I really think your family doc is your ally in this one. So they're not looking to try to convert you into something or to force you to do a thing. What they want is for you to make your decision based on the evidence that's right for you or for your family member. And I just think that having that conversation is critical and important. And this stuff is complex. And not everybody's going to have an hour like we had, to sit and talk about it during your office visit. But these kinds of podcasts can get you informed. Looking at, there are websites. For example, we have one, familydoctor.org, that does a great job just explainer things. Print it out and bring it in, talk about it a little bit, ask some questions, figure out what you need to know. But I just think there's so many opportunities for people to get smarter about their own health and be able to take back some of the power of taking care of yourself, because it was never lost. It's always been yours. Like, it's your body. You have to take care of your own body. But just like I wouldn't try to tell my mechanic whether or not the oil they picked was the right oil, I really wouldn't want to show up and tell the doctor that I do or don't want a thing. But what I do want to do is have a conversation about that oil, because before I got here, I looked it up and called some people and I got some questions, and I want to make sure that I understand why we're recommending that oil or why we're recommending that change. And I think a lot about people coming in to see me that way. Like, you're coming in, you're looking for advice, you want the best advice, and then you make the decision you need to make. So that's how I would end this conversation. But I'm so glad we had it. I think it was a great conversation.
Oh my gosh. Are you taking on new patients? And no, in all seriousness, Dr. Savoy, you have a really incredible way of explaining things. And I love that you embrace the nuance, encourage people to ask questions. These are important questions, and emphasize that just because science evolves or knowledge evolves, the recommendations evolve, that does not mean that we got things wrong. It's that we're just learning how to do things better. And it's really not a safety issue. It's a matter of, efficacy.
Software upgrade.
It's a software upgrade. Exactly. I love that. I'm going to use that iPhone analogy.
Such a great analogy.
All right. Well, with that, Dr. Savoy, thank you so much for your time and expertise today. This was such a pleasure. Thank you for all of the incredible work that you do to keep us healthy and safe.
And we will link to some of those sources that Dr. Savoy mentioned in our show notes as well.
Awesome. And thank you. Now I got to tell my mom I was on the podcast.
Oh, yeah.
All right, Sarah, take us home.
All right. Thanks so much for tuning in, everyone. We hope you learned a thing or two. I certainly did. Join us, please, next week on your trusted source for no nonsense, just science.